But however, it is still going with very good quality of both presentations as well as the judging by great judges like Rajan sir, which upholds the value of this competition. So I formally welcome all the participants this year of this quarterfinal match, and then we'll straight away proceed. Thank you.
Thank you, Dr. Sunil. Dr. Ranjan, anything to say from your end?
Nothing more to say. Just wishing all the best to all the teams in the quarterfinals. Try very best to bring out the best in you. All the best.
Thank you very much. Dr. Ranjan, we start the program. Can I have the first presentation by GMC Kozhikode? You're muted. Yeah, come. Now your time starts 10 minutes presentation, isn't it?
Yes, sir.
Yeah, go.
So, respected faculties and my dear colleagues, a very good evening to all. Representing Government Medical College Kozhikode, we are presenting the case of Mrs. X, 57-year-old female, who is a retired teacher by profession, hailing from Kalai, Kozhikode, Kerala. Presented with complaints of swelling in front and outer aspect of right thigh for past 1 year. History of present illness. The patient was apparently normal 1 year back when she noticed a swelling in front of her right thigh, which was insidious in onset. Initially, the swelling was approximately 2 into 2 centimeter according to the patient and was gradually increasing in size till 6 months back when she noticed a sudden increase in the size of the swelling to involve in front and outer aspect of her thigh. There was no history of pain or skin changes over the swelling, no history of similar swelling elsewhere in the body, no history of functional impairment of right lower limb, any restriction in movements of right hip or right knee joint, no history of numbness or loss of sensation over right thigh, no history of edema, weakness or color changes over right lower lip. There was no history of trauma associated and no history of fever, no history of recent skin pigmentation anywhere else in the body, no history of breathlessness, chest pain, abdominal distension, bone pain, jaundice or recent onset headache or visual disturbances. And there was also no history of loss of appetite or loss of weight. Past history. Patient has no history of irradiation in childhood, no history of exposure to harmful chemicals, no history of any previous surgeries to right lower limb, no history of similar swellings in past, no non-comorbidities or pulmonary tuberculosis in past. Personal history. She follows a non-vegetarian diet, sleep and appetite normal, bowel and bladder habits regular, no addictions and no non-drug allergies present. Menstrual and obstetric history. Menarche at 12 years of age, regular cycle, P3, L3 of obstetric score with normal vaginal delivery, menopause attained at 54 years of age. Family history. No history of similar illness in her family, no history of malignancies in family, no history suggestive of retinoblastoma, neurofibromatosis, familial adenomatous polyposis. Socioeconomic status, she belongs to upper middle class according to modified Kuppaswamy scale.
Coming to the general examination, patient is conscious, oriented to time, place and person, and she is moderately built and nourished with having an echo score of 1. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy and edema, and patient is affable to touch. And she is having a pulse rate of 76 beats per minute, blood pressure of 130/80 mmHg, and SpO2 of 99% on room air. And she has a weight of 63 kg, height of 158 cm, and BMI of 25.2. And on head-to-toe examination, no significant skin pigmentations, cafe-yellowed spots or freckles seen, and the gait is normal. Now, the examination of the right lower limb, a transversely ovoid swelling of approximately 15 cross 10 centimeter size is present in the anterolateral aspect of the right thigh, superiorly extending 10 centimeter below knee joint, involving approximately 40% of the circumference of the right thigh. And the surface appears smooth with ill-defined margins. There is no dilated veins, scars, pigmentation, or visible pulsation of the swelling. No other swellings not on the right lower limb. No edema or distal muscle wasting. No ulcers, pigmentation over the right lower leg. No deformity of the right lower limb noted.
So on palpation, no local rise in temperature or tenderness is noted. A transversely ovoid swelling of size 14 cross 9 centimeter, present in the anterolateral aspect of the right thigh, superiorly extending 9 centimeter below from the right inguinal crease, inferiorly 10 centimeters above the right knee joint, and involving 35% circumference of the right thigh. The swelling has a smooth surface with a firm consistency and a well-defined margins. Skin over the swelling is normal and pinchable all around. The swelling becomes less prominent on contracting the quadriceps muscle and has no change on contracting the adductor group of muscles. The swelling has restricted mobility along the axis and perpendicular to the axis of the muscle on contraction. On relaxing the muscle, the swelling is mobile and perpendicular to the axis, not fixed to the bone. Movements of the hip joint, knee joint, and ankle joint is not restricted on the right side. Sensations over the right lower limb is normal. Power in all muscle groups are 5/5. Distal pulsation, bilateral lower limbs are palpable and equal on both sides.
Now coming to the measurements, measurements at the thigh level, at the mid thigh level, for the right lower limb, it was 52 centimeters, whereas compared to the left lower limb, it was 46 centimeters. Measurements at the mid leg were same on both sides at 28 centimeters. Auscultation, there is no bruit over the swelling. Examination of the left lower limb, normal. Examination of bilateral inguinal region, no inguinal lymphadenopathy. Examination of external genitalia, normal. Now coming to the examination of abdomen. Abdomen was flat and soft. Umbilicus inverted, no organomegaly, no mass palpable per abdomen, no evidence of free fluid in abdomen, no scars except for striae alba, especially on lower abdomen, no dilated veins, normal bowel sounds heard. Other systemic examination, respiratory system, air entry bilaterally equal, normal vesicular breath sounds heard, musculoskeletal system, skull and spine were normal, central nervous system, there was no focal neurological deficits noted. Coming to the summary of this case, 57-year-old female with no known comorbidities, with no history of previous surgeries, presented with a single ovoid, transversely oriented, firm swelling of size 14 cross 9 centimeter in the anterolateral aspect of the right thigh for the past 1 year, with history of rapid increase in size for the past 6 months. The swelling was fixed to the muscle without any clinical features of distant metastasis, distal neurovascular deficit, muscle weakness, wasting of muscles, skin changes, or lymph node involvement. So our diagnosis of this case is soft tissue tumor of anterolateral aspect of the right thigh, likely malignant, most probably soft tissue sarcoma of the right quadriceps muscle. Thank you.
Team Mangala, your time for questions starts now. You have 10 minutes.
It was a very good presentation from Calgary Medical College side. Now let us proceed with our questions. Can you just tell us why do you say it is a case of soft tissue sarcoma? Why do you suspect it as a case of soft tissue?
From the history point of view, it's an elderly person who is presented with a swelling, which was 1 year of duration, and it's a large swelling, mostly more than 5 centimeter. She is a literate, and it is a deep-seated swelling, and with a history of rapid increase in size for past 6 months. And also the swelling was fixed to the muscle, and so we considered a case of a sarcoma rather than a benign swelling.
So, what are the possible DDs that you can think of in this situation?
Other than this malignant swelling, it could be a benign swelling. If there was a history of trauma, we could consider an organized hematoma. That could be a large, or it can be a myositis ossificans also. It can be even a huge lipoma that has developed over the years where the patient has neglected, but the patient has not got such history now. And it can be even a case like angiomyolipoma or angiomyxoma even.
Okay.
Why do you see a sudden increase in size as you said in your patient, there was a sudden increase in size recently. Why do you think there is a sudden increase in size? And what would be the reason for sudden increase in size?
The sudden increase in size could be, there can be areas of necrosis within the tumor with cystic degeneration. So there can be degeneration of the present tumor that can result in a sudden increase. Since it is case of a malignant one only, then there can be already we are diagnosing it as a malignant. If it is a case of neurofibroma, there can be a malignant transformation of neurofibroma resulting in a sudden increase in size.
The other possible reason it could be they can be hemorrhage into the tumor, or they can be de-differentiation
Hemorrhage into the tumor.
then there can be differentiation of certain soft tissue sarcomas, which also show a rapid increase in size, which is
Rapid
mostly
increase.
seen with sarcomas.
So can you outline some of the risk factors for soft tissue sarcoma?
The risk factors of soft tissue sarcomas are there are germline mutation that is associated with soft tissue sarcoma that you should be asking in the family history. That ones are the neurofibromatosis type 1 and also the retinoblastoma. Then there is Lee-Fraumeni syndrome, which is associated with the TP53 mutation. All these are the common familial history that you should be asking for. And also the other risk factors are previous history of radiation is associated with the development of soft tissue sarcoma like angiosarcomas. And also chronic lymphedema is another risk factor, which is usually seen in the case of a carcinoma breast, where the post-radiation and also the chronic lymphedema that is going to cause the angiosarcoma called as Stewart-Trevi syndrome. And also chronic irritation with some implants and all is going to foreign bodies are going to cause sarcomas. And also there is an occupation exposure that is there. That is the chemicals like arsenic, vinyl, and also chlorophenols, Thorotras, which is used as a radiologic agent previously. All these are going to cause various types of soft tissue sarcomas.
Is there
And
any
also in the case of HIV infected patient, there is chance of Kaposi sarcomas.
Yes. And also in HPV virus, also you can suspect soft tissue sarcoma in patient. So how are you going to proceed with this case? What will you do next?
For this particular case, first of all, we require a diagnosis of the case. And first, we will proceed with a radiological imaging, and we would prefer a contrast enhanced or an MRI of the right lower limb in order to look for the delineation and the anatomical origin of the tumor, and also for the neural, if there is any nerve infiltration, though clinically it's not there, which will be followed by a core needle biopsy, preferably a guided core needle biopsy.
Ultrasound guided core needle biopsy, Sushina.
What all do you consider when you are proceed with a biopsy in case of a soft tissue sarcoma? Suspected
In case of
soft
a
tissue
Okay. In case of a suspected soft tissue sarcoma, a core needle biopsy should be done, preferably by a surgeon who is going to do the surgery, and it should be done in the most most superficial area and most suspected area. And if at all incision, usually for a core needle biopsy, it will be true cut gun will be used, so that much incision will not be put. If at all putting an incision, it should be a longitudinal incision, and again it should not we should not raise any flaps. For core needle biopsy, we are not going to raise flaps. It should be, for core needle biopsy, it should be as close as to the incision that we are putting. But for incisional biopsy, if at all this core needle biopsy got failed, if you're going for an incisional biopsy, you shouldn't raise a flap. You should not dissect more than one plane. Proper hemostasis should be achieved, and wherever possible, no drain should be put. It doesn't mean that drain shouldn't be put, but wherever possible, no drain should be put. And if at all drain is putting, you have to do it very close as to the incision that you have done.
So in a core needle biopsy, the most important thing that you have to take care is that you should not breach the compartment, because soft tissue sarcoma respects boundaries. So you should not taking a core needle. That's the most important thing that you have to take care. And when will you said that you will go with the core needle biopsy. When will you think about an incision or an open biopsy?
When more than two attempts of core needle biopsy that is ultrasound guided is failed, then you can go for incisional biopsy. Or if the lesion is less than 3 centimeters, we can go for an incisional biopsy also. If the lesion is less than 3 centimeters, if you are suspecting a soft tissue sarcoma, you can go for an incisional biopsy also.
Yes.
Is there any role of FNAC in soft tissue sarcoma?
Actually, there is no evidence to show that there is no role in a primary soft tissue sarcoma. But if we have lymph node metastasis, we can go for a USG guided FNAC from the lymph node. And if there is recurrence of the soft tissue sarcoma, you can go for a FNAC. Otherwise, there is no, because we require an immunohistochemistry.
In all cases, do you always go with MRI first, or do you do some other investigation before an MRI?
Before an MRI?
Yes. Is there any other investigation which you would prefer to do it before taking an MRI?
Ultrasound can
we
be,
can do an ultrasound, which will be an extension of our clinical diagnosis.
so an X-ray can be done.
An X-ray of the lymph
Lymph
can be
can be
also
done.
done in order to look for any bony.
So if it is an extremity, you first go for an X-ray first.
X-ray.
Okay. So after you did a imaging and you have features of soft tissue sarcoma, and you did a biopsy, is there a role for IHC in case of soft tissue sarcoma histopathology? Role
IHC
for
actually
IHC.
will not take. IHC actually will not change the management of soft tissue sarcomas.
Okay.
IHC
So,
will be actually able to understand the IHC will be you will be able to understand the proper histological type, but the management will
The
remain the
management
same.
part of soft tissue sarcoma will not change as far as IHC is concerned, but there are certain histological variants of soft tissue sarcoma like angiosarcoma where we suspect lymph node mets, and these are chemosensitive. For such cases, an IHC would be far beneficial, and we can there are centers where we could consider a neoadjuvant therapy for such patients.
For abdominal sarcoma, Ewing sarcoma and all, we can consider a neoadjuvant chemotherapy after getting the IHC.
why the grading is important in soft tissue sarcoma?
It's because it is included in the TN. Yeah, the grading is included in the TNM staging of the disease, so it helps in staging of the disease.
Correct. Okay. Now you did you went with imaging and biopsy. So now you have a diagnosis of a soft tissue sarcoma. What other workup investigation you will do for workup?
So this is basically based on the IHC and the grade of the tumor. If it is a high grade tumor, already our tumor is more than 5 centimeters. So if it is a high grade tumor, we have to, do along with that, we have to suspect, chest pulmonary metastasis also. So we have to do a CT thorax. Usually X-ray will suffice in most cases, but these are a peripheral metastasis. So most often it will be picked up by CT thorax. So we have to do a CT thorax.
Rule for a CT thorax. If you go for an X-ray chest or a CT thorax, when will you go for an X-ray chest and when will you go for a CT thorax?
In cases of low-grade tumors or intermediate grade tumors, X-ray chest will suffice actually. But if the patient has clinical symptoms or X-ray chest shows any suspicious lesions, we may have to go for a CT thorax. Especially for those chemosensitive tumors with lymph node mets, there is a high predisposition for pulmonary mets also. So for such case, it is always better to do a CT thorax along with the MRI after that particular.
You are halfway through the mark, 10 minutes up, in another 10 minutes more.
So you said about lesions that you would see in a CT chest or nodal mets. Do you expect lymph nodal metastasis in this case?
In this case, according to this, the most common diagnosis that we put forward would be a liposarcoma, or it could be even our abdominal sarcoma, even though it is more common in pediatric age group, but it's arising from the muscle. So in this case, in case of a well-differentiated liposarcoma, we don't usually expect a chest metastasis because there is no clinical features also.
Lymph node mets, actually, there is less chance of lymph node mets in the case of a soft tissue sarcoma. Only a few malignancies are that is going to produce a lymph node mets. In the case of soft tissue sarcoma, there is more chance of development of pulmonary mets.
But if the histological variant came out to be a myxoid liposarcoma, then we have to obviously go for a CCT abdomen also, because it is highly, there is a higher chance for peritoneal sarcomatosis in such cases. So if patient has clinical features, we have to go for that also.
Is there any soft tissue sarcoma where you can see soft tissue metastasis other than myxoid type? Other than myxoid type, is there any other soft tissue sarcoma which can show soft tissue metastasis?
Brain metastasis or abdomen? Peritoneal metastasis?
Soft tissue metastasis.
Soft tissue, any soft tissue metastasis?
Round cell liposarcomas.
It's like a clear cell.
Clear cell.
Clear cells are then alveolar soft part sarcoma, which shows brain metastasis.
Brain metastasis.
Then clear cell
Angiosarcoma.
Clear cell sarcoma.
Is there any role for PET-CT in this patient?
As far as soft tissue sarcoma is concerned, for primary evaluation of soft tissue sarcoma, FDG PET there is no role. A recent meta-analysis and literature actually shows there is actually no role for FDG PET. But PET can be done in case of RECIST, that is the criteria for evaluating the solid tumors. So after neoadjuvant chemo, if we have to evaluate these solid tumors, the response of these tumors, we can do a FDG PET. Otherwise, for the primary evaluation, there is no role.
Okay, now you did a CT chest for this patient and you saw a metastasis. How will you proceed?
In the case of a soft tissue sarcoma, after dealing with the primary lesion, that we will go for a surgery for the that is for the low grade lesion, we will go for a wide local excision with a 1 centimeter margin, and for a high grade lesion, we will go for a wide local excision with 2 centimeter margin. And along with that, we will go for a pulmonary metastectomy if there is solitary lesion, and if the patient condition is favorable, and if the lesion is accessible for resection. In all these conditions, we can go for a pulmonary metastectomy along with the primary dealing with the primary tumor.
So you said you will for primary you will go for a surge. You said you're going with a surgical management. What all things you will consider before surgery in this patient?
We didn't get it. Preoperative evaluation.
Preoperative considerations in case of a extremity soft tissue sarcoma.
The primary aim of the primary aim of doing a surgery in case of a soft tissue sarcoma is a limb saving and salvageable and function preserving wide local excision have to be done. So as this patient has no neurovascular deficits clinically, and if the MRI shows no invasion to the vascular or a cortical bone invasion or neurological invasion is not there, preferably will be possible to do a wide local excision with 1 to 2 centimeter margin grossly. And if needed, we can try for a reconstruction of the muscle also.
And also, you should be, while planning the wide local excision, you should be taking out the old biopsy tract also. You should plan in such a way.
Is there any role of neoadjuvant RT in your patient?
Yes. If the size of the tumor is more than T1, and if it is a high grade tumor, if it is a deep seated tumor, and if there is a recurrence of the tumor, then there is a role for radiotherapy, preoperative radiotherapy.
Which one will you
5
choose?
more minutes. 5 minutes more.
What
We'll be going for a
post.
There are
So you're planning for, if you're planning for an RT, will you go for a preoperative RT or a postoperative RT?
For this particular case, we will offer a postoperative RT because it is amenable for a wide local excision with the surgical as well as oncological safety margin we'll be able to get. So that we'll go with the postoperative RT.
But there
What
are
are the
many
consequences of postoperative RT in this patient?
Postoperative
The dose of RT that we have to give in postoperative period will be high comparing to the preoperative RT where you can give a 50 gray because a large field have to be irradiated, and so that the toxicity will be also high.
And also, if in the primary surgery, if there are any wound complications, then the radiation, there will be a delay in getting radiation. And also, there is long-term chance of fibrosis also in the case of a post-surgery RT.
Have you heard of a terminology called as plant positive margin? And what do you mean by plant positive margin?
No.
This is usually surgeons intentionally leave a small area of margin in case of where we need to preserve critical structures, so that post surgery you can go with adjuvant radiation and we can preserve the critical structures during the surgery. That is actually called as a plant positive margin. Okay, the concept of plant positive margin comes when in extremity soft tissue sarcoma, where vital structures are closed, there is different way of excision. We have intralesional, we have marginal excision, wide excision, and compartment excision. anything that is, if you are not able to achieve a wide excision, if it's a marginal, or if it's a marginal, there is chance for satellite nodules. And if it's intralesional, there is residual tumor also is there. So in such cases, we consider a intralesional or a marginal excision, and we clip the areas and we go for a focus. Then even if there is a positive margin, we go for a focused RT post-operative. Okay. So you know what is the concept of brachytherapy in case of soft tissue sarcoma? And
In soft tissue sarcoma, we can
what are preparations you will do preoperatively if during surgery if you're planning a brachytherapy?
In brachytherapy, you'll be at the time of surgery, you'll be implanting the brachytherapy beads inside the area, so that post-operatively the patient will be they can localize that thing, and post-operatively they will be able to give the radiation.
Okay.
2 minutes more.
Suppose your patient is an athlete, what specifically would you discuss or consider regarding the options of limb salvage and amputation? Any role for prehabilitation? What is prehabilitation?
To increase the muscle mass, we can go for a prehabilitation procedures to strengthening the muscle. Exercise can be advocated for such patients for strengthening all the core muscles. And also
Okay,
post-operative basis cannot.
We can optimize the patient's physical, nutritional, and psychological status before doing surgery. That is prehabilitation.
And if you want in case of if people who are athletic, it is always better to choose for amputation than a limb salvage, because the energy that has been used for a limb salvaged limb is always lower than an amputated limb.
Your last minute. If there are any questions, you can shoot one more question.
Okay, what all things you will consider in if you're considering a limb salvage surgery? What all precautions that you will take?
A preoperative chemotherapy has to be done in most of the cases if we are planning for a limb salvage surgery, so as to decrease the size of the swelling, and if the swelling is near any neurovascular structures also, we can go for a preoperative chemotherapy.
Thank you very much. Amla can make the presentation.
Good evening, respected dignitaries and fellow postgraduates. I'm Dr. Ann from Amala Institute of Medical Sciences. Myself, Dr. Anagha. Dr. Shrija.
Myself, Dr. Amal.
Today, I'm presenting a case of a 60-year-old male who is a manual labor hailing from Palakkad, who presented with chief complaints of hematuria since 2 months. History of presenting complaints. He presented with a history of painless hematuria since 2 months, insidious in onset, intermittent in nature with 4 episodes in past 2 months, and hematuria was present throughout micturition. No history of passage of clothes, no history of calcuria or fecaluria, no history of burning micturition, no symptoms of lower urinary tract symptoms like urgency, frequency, or difficulty in micturition. No history, as it was associated with a history of unintentional weight loss of 5 kgs in 2 months. He was 64 kgs 2 months back, and now he's 59 kgs. No history of fever, abdominal pain, vomiting, or altered bowel habits. No history of bleeding per rectum or melena. No history of trauma. No history of systemic symptoms like yellowish discoloration of sclera, dyspnea, hemoptysis, bony pain, headache, or blurring of vision. Moving on to past history, he's a known hypertensive on medication since 15 years. No history of irradiation in the past. No history of previous surgeries. Personal history, he's married for past
30 years with 2 children. He consumes a mixed diet and have normal bowel habits. He has normal sleep and appetite. He's a smoker for past 35 years with pack year of 10 and no other addictions. No history of malignancy in first or second degree family members. Summarizing the history, a 60-year-old gentleman who is a known smoker with a pack year of 10 and history of hypertension without significant family history of malignancy, presented with 2 months history of painless total hematuria with significant weight loss.
So moving on to the examination. A general examination, the patient was examined in a well-lit room after obtaining verbal consent. The patient was conscious and oriented to time, place, and person. He was moderately built and nourished. The BMI was 22, and there were no enlarged supraclavicular nodes, no pallor present, no icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. His vitals were BP was 159 over 90 millimeters of mercury. Pulse rate was 85 per minute. SpO2 was 98 at room air, and he was afebrile. On per abdominal examination, he was examined in supine and sitting position, and the abdominal examination was normal, and the umbilicus was central, inverted. There were no visible lump, scar, or sinuses. There were no dilated veins, pulsations, or peristalsis noted. The respective quadrants were moving correspondingly with respiration. Hernial orifices on examination, on inspection, there were no visible cuff impulse noted. On left renal angle, fullness was noted on inspection, and the external genitalia appeared normal. And on palpation, the inspection findings were confirmed. No local rise of temperature was noted, and abdomen was soft and non-tender. A mass of size 14 into 12 centimeter palpable, spanning in the right lumbar region and right hypochondriac and umbilical region, and it does not cross midline. Medially, the extent was 2 centimeter from the umbilicus, and inferiorly 3 centimeter above the anterior superior iliac spine. The superior and lateral borders were not well defined. The surface was smooth, and the mass was firm in consistency. Fingers can be insinuated between the right costal margin. The mass does not move with respiration. There was no falling forward noted on knee-elbow position. The mass was bimanually palpable and ballotable. The mass was less prominent on leg raising test. No other masses were palpable, and no palpable inguinal nodes were noted. The left renal angle, there was no fullness or mass noted in the left renal angle. The hernial orifices were normal, and the external genitalia was also normal. On percussion, no shifting dullness or fluid thrill noted. Liver dullness was obtained at 5th intercostal space, and the liver span was 13 centimeter in the right mid-clavicular line. Percussion over the swelling gives a dull note, and the rest of the abdomen was tympanic. On auscultation, the bowel sounds were normal, and no bruit was heard over the swelling. On rectal examination, the examination findings were normal. No prostatomegaly or no deposits were palpable, and the left supraclavicular fossa was normal on examination. Other systems, CNS examination, the GCS score was 15 out of 15. No focal neurological deficits noted. As a CVS examination, S1, S2 heard, no murmurs heard. And on evaluation of the respiratory system, bilateral vesicular breath sounds noted, and there were no added sounds. The musculoskeletal system was within normal limit. So coming to the summary, a 60-year-old male who is a non-smoker with pack year of 10 and a history of hypertension without a significant family history of malignancy, presented with 2-month history of painless total hematuria associated with significant weight loss. On examination, a solitary non-tender firm retroperitoneal mass of size 14 into 10 centimeter spanning across the right lumbar hypochondrial region and does not crossing the midline, which was bimanually palpable and ballotable. So the my provisional diagnosis would be a right renal cell carcinoma.
Nikhil, you can start asking questions now.
That was a good presentation. So can you tell us the points in favor of your diagnosis related to history and clinical examination?
One second. My most popular diagnosis would be renal cell carcinoma because the clinical presentation, he has hematuria, and there is a palpable mass in the right lumbar region, which was bilateral, as well as
From the history, this is a 60-year-old patient who has a history of smoking and is also a hypertensive. All these are a risk factor which contribute to the development of RCC. And history, the painless hematuria is a key characteristic of an RCC.
Just a few points in your presentation. You have mentioned it as a right renal mass, right? But in inspection, you have seen a left renal angle fullness. That cannot be there. Maybe a typing error. So redo that. Left renal angle fullness was written, and on right on palpation, you have got a right renal angle fullness and right renal mass. It's okay. Then, so you have told risk factors. So what are the three, or let me say it's three itself. What are the established risk factors for RCC?
Smoking is a established risk factor.
Yes.
Then hypertension.
Yes.
Then obesity.
Obesities. So these, according to literature, these three are the three defined and established risk factors. All other risk factors is also there. So it was a right renal mass, right?
So now
Yes,
you
yes.
have a hematuria in your case. So what is the classical triad that we see in RCC?
In
And
class-
what is the most common presentation in an RCC?
In RCC, the classical triad is painless hematuria, palpable mass, and pain, flank pain. But it is only the classical triad is only seen in 10% cases.
So what is the significance of this classical triad if it is present?
Because it is an advanced, suggestive of an advanced disease.
Yes, it is otherwise called as a too late triad.
Too late.
So it signifies poor prognosis. And so what is the most common presentation in an RCC?
Painless hematuria. It is usually an accidental finding.
Yes, it's an incidental
Incidental
finding.
finding.
60% of the patients will present with as an incidental.
So now you have diagnosed your case as a right renal cell carcinoma. What are the other differentials you think of in your patient?
It's a large swelling. It's a 14 centimeter swelling that is present in the right lumbar region. It's almost occupying whole of that area. So what would you consider as your differential diagnosis?
Other
Just an
possible differential would be a ascending colon carcinoma. It can be a carcinoma arising from the adrenal gland. Then it can be a retroperitoneal sarcoma or a desmoid tumor, and it can be hydronephrosis, a large hydronephrosis, or angiomyolipoma. These are the probable diagnosis.
One thing that you, what is the one thing that you are missing? One thing that is a large retroperitoneal tumor associated with hematuria will be there.
A soft tissue sarcoma.
Urothelial
Urothelial
carcinoma.
carcinoma is another thing.
Now, the one thing that you should be telling is an PKD. That is the adult polycystic kidney disease, which will be mimicking the like this, will be presenting like this. Okay, now coming to your history part, like you tell that the patient is having a history of hematuria. So how are you going to differentiate a hematuria between a renal cause and other causes of the genitourinary system?
Hematuria can
How are you going to
basically
differentiate?
hematuria can basically be classified as initiation hematuria, total hematuria, or terminal hematuria. Initial hematuria is mainly seen in lower urinary tract diseases or lower urinary urothelial carcinomas and all. And total hematuria is commonly seen in malignancies of kidney, prostate, or bladder. And terminal hematuria is also seen with bladder, prostate.
Actually, it is like initial hematuria is actually seen in the case of pathologies of urethra and prostate. And terminal hematuria is usually seen in the case of bladder neck pathologies. And the total hematuria is usually seen in the case of bladder and above. bladder and above. So how are you going to differentiate between a hematuria because of a bladder cause and a renal cause?
Usually the hematuria with a passage of clot is more suggestive of a bladder etiology than a renal etiology. Then there will be frank hematuria in case of bladder carcinomas than a
What is there will be in the history? One thing that will be there in the history, bladder pathologies, the patient will be having dysuria.
clots
Severe
or
dysuria
passage.
will be in the, okay. Dysuria will be there in the case of a bladder pathology. And also one more thing, like with the help of clots, how are you going to identify the tract, like upper tract or lower tract, or bladder
by
or
the
renal cause?
There is passage of clots. By the shape of the clots, we can differentiate between upper urinary and lower urinary. If it's a serpentinous shaped clots, it will be usually upper urinary. And if it's bladder related, it would be a shapeless hamartous forms of clots.
Right, like the passage of large amount of clots means what? What does it signify?
A significant bleeding.
Significant bleeding. Why there is like usually why there is no significant bleeding? Usually, if it is a small bleeding, there won't be clots. What is the reason for that?
Clot lies.
Clot is lies with the help of urokinase that is produced by the renal tubular epithelium. So if there is a massive bleed, then the urokinase will not be able to lyse this thing. So that is the reason why like the history of clots is important. Okay. So now coming to the past history, what are the relevant past histories that you should be asking in this case? You have said that the patient is having a history of hypertension for the past 15 years.
Yes.
Yes.
So beyond, it's a established risk factors. Okay. So what are the causes of hypertension in renal cell carcinoma? Your diagnosis is an RCC. So
Hypertension
How
in renal
renal
cell carcinoma is mainly seen because of the paraneoplastic activity, where the renal cell carcinoma secretes renin that can activate the RAS systems that can cause
okay. Other
hypertension.
causes?
Other causes that this mass itself can compress over the renal vessels, which can in turn lead to hypertension. And then
Within the tumor, there can be AV fistulization, arteriovenous fistulization that can again result in this one. And also there can be CNS mets, and increased intracranial pressure can also cause. And again, a polycythemia, which is another paraneoplastic syndrome, itself can cause hypertension.
What is the relevant family history that you will be asking in this patient?
What is the significance of family
And
history?
the significance of family history too.
History of BHL syndrome, hereditary papillary syndromes, Bird-Duke syndromes. These are all associated with renal cell carcinomas.
And if it is associated with some syndrome, what is the difference that will be there in the management part?
Usually, if it's associated with syndromes, that can the presentation will be bilateral and will be an early disease. So we'll have to consider of nephron sparing nephrectomy in such cases.
Yes. Okay.
Now, if there is pain in renal cell carcinoma, it's a huge mass, right? So pain, what does this pain significate, or what are the causes of pain in case of a renal mass? It's not RCC, just a renal mass. What are the causes of pain?
the pain can be because of stretch of the capsule of the renal kidney, or it can be due to the compression to the adjacent structures, which can contribute to the pain. Then sometimes there can be hemorrhage into the large mass, which can also present with pain. Then passage. Then
Then there can be clot colic. There can be clot colic. And as you have said, necrosis or capsular distension. We call it as capsular distension.
So on examination, you have said that there is a pallor. So why does pallor occur in an RCC?
That is mainly because when this tumor replaces the renal parenchyma, the erythropoiesis will be impaired. That can lead to anemia. If there is gross hematuria, that can also the patient can also present with anemia.
Then another thing is anemia of a chronic disease.
Because of interleukin and chemokine release.
So what is it?
So you have checked for icterus. Why does what does it signify in this case?
Jaundice.
Jaundice. Why do jaundice occur in an RCC?
In paraneoplastic syndromes, can like Stoffer syndromes can lead to non-metastatic liver dysfunctions that can cause, by the action of interleukin-6, cause elevation bilirubin and ALP.
So any other cause for icterus that you can suspect in an RCC?
Then metastasis to the liver can also present. I mean, the patient can present with icterus.
So anything else you are missing in general examination? You have almost covered everything. But anything else you have to do in general examination? Any other features you have to check for in case of a renal mass? If your clinical
We are
picture is
half-
of renal mass in general
We are
examination,
halfway through the mark. We have halfway through the mark, 10 more minutes.
We can look for any skin pigmentation or skin lesions which can contribute towards the familial diseases. That can also
otherwise,
be.
in case of a in case of a renal mass, you have to look for features of renal failure. Patient might be having this for a long period. So any features of renal failure like clotted tongue, any features of fluid overload, if there is JVP elevated, all these things will actually change the management protocol itself. So you have to check in examination whether patient has features of these renal failure. Okay.
Does your patient has pedal edema?
No.
No pedal.
Does your patient has... So
No,
what is
no.
the type of pedal edema do you expect in a RCC?
It is bilateral mostly, and it is non-pitting type. Then
What is the cause of
What is the
edema?
cause for edema?
it
What is the cause for edema?
This either one. It can be when the large mass compress over the IVC that can lead to edema, or the tumor thrombus which can obstruct the IVC can also lead to edema.
And also because of nephrotic syndrome, which is an established paraneoplastic syndrome, which may cause a lower limb edema.
What are the other paraneoplastic manifestations that you can see in an RCC?
Just list it out.
You can see elevated ESR levels may be there.
Which is the most common?
Most common.
Most common is ESR. Then
Hypercalcemia.
Yes.
Hypercalcemia.
The other things are increased
Polycythemia.
erythropoietin, polycythemia, anemia, Cushing syndrome due to ACTH production, hypercalcemia due to PTH-related polypeptides.
okay, now coming to your examination part, what is ballotable? What is ballotability, or what is a ballotable swelling? How will you do that?
A pedunculated swelling that can be moved antero-posteriorly is called ballotable masses.
Ballotable mass. Then how can you get a bimanual palpable swelling in a ballotable swelling? You told your swelling is bimanual, palpable, and it's ballotable. So how will that be possible? It's a large swelling, right? So you have a watching hand and a displacing hand. So you get a large swelling which is bimanually palpable. Then you have no more space that particular swelling to become ballotable. So it will not be. It's why, like, if it is a bimanual palpable swelling, then it cannot be ballotable. And you got the reason? Ballotability means you require a space around that, like a fetal head. That particular thing will be, it will be ballotable. If you are touching with the posterior hand, it will come and hit over your anterior. It's for the posterior, retroperitoneal or a renal mass specifically, we tell it as ballotable swelling.
So if it is a renal mass, if it is bimanually palpable, it is not ballotable.
It won't be ballotable. It's a wrong statement.
So you are getting a mass in the right hypochondrium and extending to the right lumbar region. So can it be a gallbladder mass?
Yeah, it can be a
Or
gallbladder.
what are the feet?
From the history, it is
Can be a
not, but
gallbladder mass.
gallbladder mass can also reach up to lumbar
So
region.
what are the features of a gallbladder mass?
Empyema gallbladder is usually seen. Such large
Okay, sir.
masses.
What are the features of a gallbladder mass? What are the clinical features of a gallbladder mass?
Incontinuous with the liver dullness, usually on percussion. Then we won't be able to insinuate our fingers between the ribs. Then Murphy sign may.
That is only if it is inflamed. Gallbladder mass is usually seen and felt. It is more usually superficially palpated and depalpation, and the gallbladder mass will be having an intrinsic mobility, and it will be globular in shape, and also it will be continuous with the liver dullness. So these are the and also it will be moved. It will move with respiration, and it's an intraperitoneal mass. So these are the things which favors for a gallbladder mass, unlike the renal mass, which will be ballotable or bimaly palpable.
One thing you missed in your examination and everything is intrinsic mobility. It plays an important role. If it is an intrinsic mobile swelling, it will be an intra-abdominal swelling. This is a retroperitoneal organ. So
It is
you have to tell it as there is no mobility, or you have to mention it there. Now, what is the significance of examination of your external genitalia?
Because in renal cell carcinomas, if thrombus is in our case, it is a right-sided swelling. If it is a left-sided swelling, if the left
In both right side as well as in left side, you may get external genitalia, you may get varicoceles. You're basically looking for the external genitalia in any undescended testis or varicoceles are present. Okay. So now you have a case of renal cell carcinoma. So how are you going to proceed with your case?
We'll go with the routine investigation, like your routine urine examination will do, then a complete blood count to look for the anemia, ESR level, and we'll look for the calcium levels also in the blood, and we'll go with the renal function test to know the to proceed with the further investigation and to know the performance status of the kidney. Then after that,
what is the investigation?
Diagnosing.
What is the diagnostic investigation that you are going to do?
Contrast enhanced ACT with a delayed phase.
So if the RFT is deranged, will you go for a contrast enhanced CT?
No, if the RFT is deranged, we prefer to go with an MRI rather than a CACT.
MRI is usually gadolinium contrast.
Gadolinium contrast, right?
Which it will also cause
nephrotoxicity.
So a plain MRI or a non-contrast CT is preferred. Is there any other investigation that you can think of? Any contrast-induced investigation that you can think of other than the CT and MRI? Have you heard about contrast-enhanced ultrasound?
You can do a contrast-enhanced ultrasound, but that too, it's basically for those patients with eGFR of less than 30. Okay, so first of all, you have to calculate eGFR. It's must. You have to check for the eGFR. If it is more than 45, you may go for a contrast-enhanced. And if it is, say, borderline, you have to hydrate the patient properly and do a contrast-enhanced treatment. Otherwise, you might have to go with non-contrast things. And will you do a biopsy for this particular case? Why don't you do a biopsy for diagnosing this case?
In our case, we don't need a biopsy, actually. Then biopsy is usually done because RCC is actually a clinical and a radiological diagnosis. And for the management, we always doesn't require a biopsy. As in our patient, it is a resectable tumor, which is...
What are the indications for doing a biopsy? What are the indications for doing a biopsy?
Even it's... biopsies are done when it is when the diagnosis is not confirmed, there is suspicious malignancy is not confirmed, when there are other suspicious diagnoses, when it is an inoperable tumor, when we are planning for a palliative or a near palliative systemic therapy.
Okay.
And if you are also
active surveillance,
So before tumor ablation also we can go for a
should confirm.
What will be the findings? Just a quick recap of what all will be the findings that you will see in CECT for a renal mass.
We'll see an enhanced lesion. If it's a if it is a renal cell carcinoma, we'll see an well-enhanced lesion in the arterial phase.
What enhancement? How much enhancement? Because angiomyolipoma will also enhance in CT. RCC will also enhance in CT.
In angiomyolipoma, we can also see fat in RCC.
Usually it will be more than 20 Hounsfield. 50 to 20 will be the Hounsfield. Whereas in angiolipoma, it is mostly less than 20. What are the histological subtypes that you will get in case of a renal cell carcinoma?
The most common one is the clear cell carcinoma. Then it can be a papillary carcinoma, chromophobe RCC. Then sarcomatoid variant, endocrine type RCC, non-endocrine type RCC.
Infiltrating one.
Infiltrative type. Infiltrative type of renal cell carcinoma.
Which one?
Collecting duct of Bellini.
Collecting duct or renal medullary. So how will you going to manage this case?
So first we'll go with the radiological investigation. And
we have done that and we have confirmed with an RCC. Now, how will you do the further workup?
What is the next step?
Yes, what? Excuse me.
You require a metastatic workup or not? Whether you require or not?
Yes, we'll go with the CT thorax.
CT thorax. Anything else? Usually, a chest X-ray will suffice in case of a RCC because our pulmonary meds will show as a cannonball metastasis if it's all present. A bone scan is required if there is symptoms of bone pain or anything. What type of metastasis bone meds you get in an RCC?
Osteolytic.
You call in RCC you have a specific bone meds. Like in papillary you have pulsatile bony meds. In papillary carcinoma thyroid and RCC you get a pulsatile. Follicular carcinoma thyroid and RCC you will get a pulsatile bony meds. Okay, so you will manage now proceed with your management. After the workup, further
We'll be going for staging the disease, right?
Staging.
Staging the disease. So, what is the difference in staging as far as adrenals is concerned? What is the difference in staging when it comes when there is a contiguous involvement of adrenaline gland, or whether the adrenaline is separately involved? What is the difference in staging that comes there? Either the adrenal gland, yes.
If adrenal glands are involved, it will be a T4 lesion.
Okay. If it is a contiguous involvement,
it's a T4.
If it is a separate
It's a
involvement,
lesion that is, it is beyond the Gerota's fascia.
Okay. If it is a non-contiguous involvement,
what is it?
if it's a non-contiguous involvement, it's metastasis. Okay, it's from an M1 disease. It's a continuous involvement, it is that. So that's about the staging. And
what is the most important prognostic factor in the case of RCC?
It is the renal parenchyma, the amount of the. If you're planning for a
it's the histological grade, the pathological subtype is the most important prognostic factor that you will consider in case of an RCC. So what are you going to do with this case?
Just 1
your
minute
management
more. Just 1 minute more.
What is your management?
So we'll first see if there is any IVC involvement is present or not.
Okay.
And accordingly we will plan for a surgical management.
What is the surgery that you are doing?
We'll go for a radical nephrectomy.
What is
the
radical?
radical nephrectomy?
What is a radical?
Radical nephrectomy.
Classical radical nephrectomy include removal of the affected kidney, ipsilateral adrenal gland, then the Gerota's fascia, then the lymph nodes up to the renal vein. But in nowadays, if there is only adrenal gland is actually involved, and if there is involved lymph nodes are only removed.
Which one will you like it while you are doing a nephrectomy, a renal artery or a renal vein? Which one will you ligate first?
Renal artery is ligated first before
Why?
the vein. One is it can shrink the to avoid tumor
bleeding also. Bleeding also can be.
What is the arrangement of these structures? Vein, artery, and ureter in the renal hilum? Which is anterior, which is posterior?
Vein is anterior, then followed by artery and pelvis.
Renal pelvis.
What is the management of metastatic RCC?
If your patient has got some meds, will you still
RCC?
proceed with this particular radical nephrectomy, or will you go for something else?
Based on the state, if it's here comes single lesion or if it's an oligometastasis or distant metastasis, based on that, the treatment protocol will change.
It will not change.
Thank
Basically,
you.
for nephrectomy, you have to do a
Last question.
cytoreductive
Last
nephrectomy,
question.
whether it is palliative or
Last
cyto. Okay. Cytoreductive or palliative, you have to go with nephrectomy.
Thank you very much. I'll
Thank
just
you.
call upon the examiners for quick comments. Dr. Kailasnathan. You're muted now. You're muted now, Kailas.
Can you hear me?
Yeah, now yes.
So congratulations both teams. Both teams presented very well, and good discussion. Covered almost all points. I think nothing more to add. A few points regarding the soft tissue sarcoma. They can ask about the what is pseudocapsule. Why? What are the grades? What is the difference between high grade and low grade? Such few questions. Regarding the renal cell mass, why gallbladder mass is compared with the renal mass. I didn't get that. It's an intraperitoneal mass. The other one is a retroperitoneal mass. Those are the few comments.
Dr. Tail. We'll go to Dr. Sanjay Kumar.
Good morning. Very good discussion. The question is whether a palatable and bimanually palpable mass. So Dr. Sunil also has raised the question there. I think palatable, bimanual, both can be possible in single mass depending upon the size of the mass there. So that is usually the dictum that we will talk about. Then another problem that is we need to be clarified is radiotherapy in sarcoma, whether you will give a pre-operative or better, post-operative. There's some difference in different centers there. There is no universal acceptance. You can have a post-operative also in some patients. No need to have a pre-operative. And regarding the soft tissue sarcoma, I think regular questions are usually being asked what are the soft tissue sarcoma in examination purpose. So soft tissue sarcoma with nodal mets, usually you will get it. That is the usual question. And the radiotherapy induced soft tissue sarcoma, that questions usually we ask in the examination. That's all. I think a very good discussion. Congratulations for both teams.
Both
the teams, Team Amla and Calicut performed well. I have two suggestions. One, for Amla team, you should have included more questions from history part and clinical examination part. Actually, questions were very minimum. 2 or 3 questions only asked from that area. Then also, most important is when you present a case, don't miss the side or wrongly place the side. In your slide, it was like left renal angle. That is wrongly given. Then about Calicut, when you are asking questions, same questions asked by 2 persons same time. Don't repeat like that. For example, family history, differential diagnosis, cause for edema, like that. Then most important is in your whole questioning section, only 1 minute spent for treatment part. You should ask more questions on treatment than its complications. Okay, that's also important point I noticed. Otherwise, questioning and answering 2 sessions, both the teams perform well. Congratulations. Thank you.
Thank you very much. Both the teams. Couple of clarifications from my side. One is the Amla told about HPV and sarcoma. It's mostly HPV and carcinoma. It's not sarcoma. Second is they said that there is no role for an IHC, Calicut. IHC is very important in finding out the cell lineage, whether it's spindle cell in origin, brown cell in origin. The treatment entirely varies depending on the IHC. So it's an important tool, to decide which cell lineage. The prognosis also, Ka67 when it comes, it has got, the other. The commonest reason for a renal cell is, as they have said, it's incidental. PUO, pyrexia of unknown origin, is another common way of presenting, the renal cell carcinomas. So these are some of the things, and the hematuria is actually a very elite presentation. That's all from my side. We move to the second group of presentation. Second set of the second teams are GMC Trivandrum and GMC Alleppey. Government Medical College Trivandrum and Government Medical College Alleppey. Government Medical College Trivandrum, can you just come online? Okay. Can you all sit together? Good evening. Yeah. So Team Alleppey, Team Trivandrum is the first one to make a presentation. Yeah, please, Trivandrum, you can share your slides.
Just a second, sir. We're just trying to upload the presentation.
Should that mean that we'll do it or Alleppey should do it?
Okay. No, that's not.
Where is the can you the same name of the
Go ahead, go ahead.
Good evening, everyone. Myself, Dr. Samuel, Dr. Anana, and Dr. Priyamad and Dr. Sandeep, representing Trivandrum Medical College. We are presenting a case of a 65-year-old male who's residing in Kallambalam, Trivandrum. He's a daily wages laborer by profession. He's educated till the 9th standard and belongs to the low socioeconomic status. He presented to us with a swelling in the right upper neck for the past 4 months. Patient presented with a swelling on the right upper part of neck for the past 4 months. It was insidious in onset and was smaller in size initially and rapidly progressed to the present size over the past 1 month. There is no history of pain over the swelling, no history of loss of weight and appetite. Sorry, there was history of loss of weight and appetite present. There was no history of fever or night sweats, no history of swelling or lesions elsewhere in the body. He did not give any history of throat pain, dental caries, ulcers in the mouth, toothache, pain or difficulty in swallowing. There was no history. Sorry, sir. There is no history of ear pain, hearing loss or voice change or speech impairment. There was no history of nasal obstruction or nosebleed. No history of facial pain, deviation of angle of mouth to one side or loss of taste. He did not give any history of chest pain, cough, breathlessness or bloodstained sputum. There was no history of headache, loss of consciousness or vomiting. And there was no history of abdominal pain, distension, yellowish discoloration of eyes or urine. He did not give any history of altered bowel habits or passage of blood-stained urine. In past history, he is a known case of diabetes mellitus for the past 12 years and is on oral hypoglycemic agents. There was no history of radiation exposure, history of blood transfusions. There was no contact with persons with tuberculosis. There was no history of previous surgeries or drug allergies or any history of previous malignancy. In personal history, he follows a non-vegetarian diet. He has normal sleep, but there is loss of appetite. He has history of significant weight loss, where he has lost 7 kgs over the past 6 months. He has been a smoker for the past 32 years, and he used to smoke almost 15 BDs a day. But he has stopped for the last 4 months, and his smoking index is 480. He is an occasional alcoholic for the past 32 years. There is no history of high-risk sexual behavior. In family history, he has 2 children, all healthy. His mother and father died of natural causes at old age. He has 3 siblings, and there is no history of malignancies or tuberculosis in the family.
Coming to examination, on general examination, after taking informed verbal consent, patient was examined in a well-lit room in sitting position with adequate exposure from head to foot. He was conscious and oriented with an ECOG score of 0. His weight is 60 kg and his height is 170 centimeters. His BMI is 20.8 kilogram per meter square. There is no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pedal edema. His pulse rate is 92 per minute as recorded in right radial artery with regular rhythm, normal volume and normal character. His BP is 120 per 80 mmHg as measured in right arm in sitting position. His SpO2 is 99% in room air. Respiratory rate is 16 per minute. He was afebrile upon examination. Coming to local examination, On inspection, there is a 3 into 5 centimeter swelling, there is a 3 into 5 centimeter well-defined ovoid swelling with a craniocaudal extent from 2 centimeter below the angle of mandible on right side to 8 centimeter above the right clavicle. Anteroposterior extent from 1 centimeter anterior to the anterior border of right sternocleidomastoid to 2 centimeter from the posterior border of the right sternocleidomastoid muscle. The swelling appears to have an irregular surface and is non-pulsatile. The most prominent part of the swelling appeared to be tethered to the overlying skin with a positive platysma site. No change in size of swelling was noticed on contracting the right sternocleidomastoid muscle. A prominent external jugular vein is seen on the right side. There is no ulcer, no scars, no sinuses, or any other visible swellings in the neck. Coming to palpation, there is no local rise of temperature or tenderness. A 3 into 5 centimeter hard swelling was felt on the right side of the upper neck. It was 1 centimeter anterior to the anterior border of the upper 1/3 of right sternocleidomastoid, extending 2 centimeter posterior to posterior border of right sternocleidomastoid muscle. It was about 2 centimeter below the angle of mandible and about 8 centimeter above the clavicle. It had an ovoid shape, irregular surface, well-defined margins with a restricted mobility. The mobility was more restricted upon contracting the right sternocleidomastoid muscle. The plane of the swelling was deep to deep fascia with the involvement of right sternocleidomastoid muscle extending to the overlying skin. Skin over the swelling was not pinchable in the most prominent area of the swelling. There were no expansile or transmitted pulsations over the swelling. Carotid artery pulsations and superficial temporal artery pulsations were felt in its normal positions bilaterally. Trachea was central. No other swellings were palpable in the neck. There is no parotid, submandibular, or thyroid swellings palpable. On percussion over the sternum gave a resonant note, and there were no bruit heard over the swelling. Coming to examination of oral cavity, the mouth opening was adequate. Lips, gingivobuccal sulcus, tooth, gingivolingual sulcus, tongue, floor of mouth, palate, tonsillar pillars, retromolar trigon appears normal. Uvula was central, bilateral tonsillar fossa, there were no fullness. Movement of the tongue were not restricted and there was no deviation of tongue. There is no palpable swellings in the floor of mouth. Examination of nasal cavity were within normal. No suspicious lesions noted over the skin surface. Examination of cranial nerves were within normal limits. There is no any features suggestive of Horner syndrome. Examination of other systems. On respiratory system, air entry was bilaterally equal with normal vesicular breath sounds. Per abdomen was soft, non-tender, no mass palpable, no organomegaly, normal bowel sounds were heard. On rectal examination, normal tone, no mass palpable, no mass felt, grade 1 prostatomegaly with a smooth surface. Central nervous system, no focal neurological deficits. Coming to summary, a 65-year-old male who is a chronic smoker and a known case of type 2 diabetes mellitus, presented with complaints of painless swelling in the right side of the neck for past 4 months, which was rapidly increasing in size over the past 1 month. He had a history of loss of appetite and significant loss of weight. Upon examination, there was a 3 into 5 centimeter hard swelling with irregular surface palpable in the right side of neck with restricted mobility and skin fixity. There was no generalized lymphadenopathy or any evidence suggestive of primary malignant lesion anywhere else on thorough clinical examination. Our provisional diagnosis is right level 3 cervical lymphadenopathy, possibly metastasis from an unknown primary.
Malathi, you have 10 minutes now.
It was a nice presentation. Give me another 3 differential diagnoses for your diagnosis.
So, in an elderly male like this with a chronic swelling, apart from carcinoma for a lymph nodal mass, we are looking at TB lymphadenitis possibly a lymphoma as well. And other chronic infective conditions like fungal conditions can also be taken into consideration. That's it. For other soft tissue swellings, if you are considering, it could be carotid body tumor or schwannoma as well. But that is very rare in our case.
So, what are the points in favor of your diagnosis? Say it is
In
carcinoma.
history, the age of the patient, the duration in which he developed the symptoms, the fact that he had not had any pain over the swelling, and also significant loss of weight, points, and also on palpation was hard and fixed. So it all points to a malignant sort of a swelling. And in the history, we have asked for any sites, any malignancies or cancers which could lead to a metastasis and present as we have as a nodal mass in the neck. So as you can see in the provisional diagnosis, we have diagnosed it as carcinoma of unknown primary, as we have not characterized any primary site after thorough clinical examination in this patient.
Did you ask for the history of any radiation? No, what is the significance of the previous history of any radiation in your case?
So radiation is a known risk factor for head and neck carcinomas, especially squamous cell carcinomas. It's established risk factor. So that is why we had asked that in this.
Also, history of any childhood malignancies, treatment given as radiotherapy. Also, there is also a risk for malignancy in this elderly patient. Okay. You asked for there is no significance of so no history of autalgia in this case. Why did you ask for the history of autalgia in this case?
Well, certain malignancies in the oral cavity or the oropharynx can actually infiltrate into the lingual nerve. And from the lingual nerve through the auricular temporal nerve, there's something called referred autalgia. And that is why you can get ear pain in such cancers. And also in certain cancers in the nasopharynx, it can block the eustachian tube also and cause chronic otitis media. And that also results in ear pain. So we just wanted to rule out that.
You said no, in the there is no higher sexual behavior. What is the significance of that sexual behavior, higher sexual behavior in this case?
Well, higher sexual behavior such as patient can have HIV or syphilis, and in, that can also be a cause for a lymph node mass in a person.
And also oral engagement in oral sex and everything is a high risk factor for contracting HPV infection, which is very important in the management part of if at all our diagnosis proves to be right.
Epstein-Barr virus history also significant in this case.
Yes.
What is the significance of if there is a history of HPV positive case? This is a case of HPV positive. What is the significance for asking whether it is HPV positive or HPV negative in this case?
Okay. So HPV positivity leads to usually HPV positivity for changes how we are going to stage the disease and correspondingly how we are going to manage the disease as well. In HPV positive tumors generally have a better prognosis and the mainstay of treatment is usually chemo radiation instead of going for surgical management. Yes.
So how do you examine a neck swelling? Any neck swelling. So what are the steps or procedure?
First on inspection, we will look for the symmetry of the swelling and also the size, surface, site and extent of the swelling. And also on palpation, we have to look for its consistency. It's very relevant because in a malignancy, especially secondaries, it will be hard, fixed. In case of a lymphoma, it will be rubbery consistency like that. And also inspection, then we have to, beyond that, we have to examine the oral cavity and also for other swellings like thyroid, other submandibular gland and parotid gland. And also we have to check for all the pulsations also.
So how do you palpate a neck swelling?
We are asking what is the method of palpating neck swelling?
After getting consent, we are going to say that, okay, can I go behind the patient? I'll be going behind the patient. And I'll also instruct the patient to tell if he's feeling any pain when I'm palpating. So I'll be going behind the patient and then I will start my palpation from the submental region, going backwards, palpating the preauricular nodes and the parotid along with that. after which I'll be palpating the post-auricular nodes, then I'll be palpating the occipital region. While I'm back, I will also be looking for any kind of hidden primaries in the scalp, following which I'll be coming down, I'll be going down the sternocleidomastoid and also the posterior triangle to look for any swellings over there, following which I'll be going for a supraclavicular fossa examination, and I'll then converge at the thyroid to look for anterior neck swellings. Same time when I'm looking at a swelling, once I characterize it, for performing the other special test, if I'm getting a better view on the lateral or the medial side, I'll then ask the patient's permission, come there and do all the tests that my colleague had earlier told.
Any particular position that you'll ask the patient to take up?
With slight neck flexion always helps.
Why? Why do you ask for neck flexion?
So if the deep fascia is taut, then it will we will not be able to palpate all the margins and everything. So for better palpation,
the muscles and fascia.
Yes,
And
yes.
flex to the side of your palpation.
Patient will be in the sitting position. We have to stand behind the patient and ask the patient to partially flex the neck to the affected side. And we have to place the our one hand on the head of the patient and the other hand for palpation of the swelling. For that, for relaxing the muscles and fascia of that side, we have to tell the we will do the passive flexion and also tell the patient to flex the neck to that examining side. So that examination will be easier.
How will you differentiate infective node and metastatic node clinically? What is the features?
An infective node, a metastatic node would be hard in consistency, and it can also be fixed. There will be restricted mobility. And whereas an infective node, and also in metastatic node, you won't get any tenderness. It will be painless actually. And whereas on the other hand, in an infective node, it won't be hard, but it will be firm. It can be firm depending on the chronicity of the infection, and it can be tender also. And little warmth will also be there depending on the acuteness of the condition.
What is the significance of any sinus or ulcer over the swelling?
Well,
over the neck?
The next possible differential diagnosis would be TB lymphadenitis. And as you know, the natural history of the process of the TB lymph node is such that it can cause a cholesterol abscess, which can further penetrate into the skin, forming a sinus, and then that sinus, when the discharging sinus, will cause some skin irritation and ulceration, and leading.
Other than TB lymphadenitis, what else?
Sir, so also in a metastatic mass, ulceration over the swelling will indicate extranodal extension.
Other than metastatic mass?
We are not sure.
Suppose there are multiple sinuses just below the mandible.
Actinomycosis is a possibility.
What is the causative organism?
Sorry?
Causative organism or actinomycetoma?
Can you tell the causative organism of actinomycosis? That is, we are asking.
So there is there are two types. We have fungal actinomycosis, bacterial actinomycosis, which have a whole myriad of organisms. Actinomyces species, Nocardia species, and also Mozzarella mycetoma can all cause this.
There can be branchial fistula also. That also can be a differential diagnosis for a sinus.
What is the typical location of fistula? It's a congenital fistula. What is the typical location? It will
congenital branchial cyst. It will be always
fistula. Sorry,
branchial fistula
or sinus. Yes, please carry on.
We are halfway through the month.
Junction of the lower two-third and lower one-third and the upper two-third of the.
Okay, what will you look for in an inspection in face and upper chest in this case? Especially
we'll be looking for facial asymmetry for cranial nerve involvement. In the upper chest, there could be again gross lymphadenopathy could be there. Skin changes.
Venous engorgement. If suppose there is venous engorgement, why would that be?
So mediastinal lymph nodal mass can cause venous engorgement, and that can also be presenting as a primary mass for an unknown primary. pediatrial
Okay,
masses can
in your
cause.
case itself, the cervical lymph node is so large that it can compress the jugular vein and cause venous engorgement.
Absolutely. Absolutely.
That is one. Any reason for wasting of neck muscles in your case? Should you look for that?
In chronic, in immunocompromised patients, TB is a possibility. So because of which any wastings and signs of malnutrition, not only in the head and neck, all over the body, will be giving us
Again,
a
same
presumptive.
cause. I'm saying pressure. This large mass causing pressure on the local nerves can cause wasting of muscles also.
Okay.
Okay, so define carcinoma of unknown primary.
So it is a clinical syndrome which is characterized by histologically positive metastatic malignancy in which the primary site could not be detected after thorough clinical examination and relevant investigations.
So by relevant investigations, what all are they?
So here we defined a clinical cup. So if we are going to go for a true occult primary, then in the relevant investigations, we are going to go for, like examination on the general anesthesia of the oral cavity and also a triple endoscopy with a nasopharyngoscopy, laryngoscopy, bronchoscopy, esophagoscopy, and also imagings like CCT, MRI, PET-CT. And
how do you proceed in this case? As in this case, what is the next step you will take?
So in this case, first I will do investigations to confirm my diagnosis, which will be first to take a USG to characterize the lymph nodal mass to see the relation to the structures in it. Following which I'll be taking a USG guided FNAC along with the cell block. Then I will also be doing a basic chest X-ray because in 27% of cases of lymph nodal TB, there is going to be positive PTB as well. So after ruling this out, if I'm ruling out TB as a presumptive diagnosis, the FNAC cell block, I'll be getting a histological answer. And still, if it's inconclusive, I will be going for a either a true, I can go for a true cut to do additional tests, but I will also be doing a CCT and an MRI of the head and neck region, especially to characterize the skull base and everything. Then I'll be going for the triple endoscopy. If the CCT and MRI is not able to characterize the primary, then I'll be going for a PET-CT as well before going for the triple endoscopy. And very importantly, in the FNAC that I am doing, I'll be testing for the P16 antigen to look for HPV presence. And if that is present, like we previously discussed, the management will change. If in spite of all this, I'm not able to characterize a primary, I'll be going for a ipsilateral palatine tonsillectomy and sending it for an intraoperative frozen section. If that is also negative, then I'll be going for an ipsilateral lingual tonsillectomy. And if that is also negative, then I will go for a contralateral tonsillectomy, but the consensus on that is still not very commonly.
So how will your suspicion change based on your FNAC report?
So the FNAC, possible FNACs that can come is, it can get a confirmed squamous cell carcinoma, it could be an adenocarcinoma, or it could be a poorly differentiated carcinoma. Most commonly in upper neck node, what we are expecting is a squamous cell carcinoma. And after this, as I described, I will be doing the same things for the squamous cell carcinoma. And if I am not able to characterize a primary, I will be going for in spite of all these investigations, if I'm not able to characterize the primary, in our setup, we will be discussing in an MDT as to how to proceed. And since it's a bulky disease, we'll be going for a chemoradiotherapy. If it's an adenocarcinoma, then we will be going for, again, more IHCs like pancytokeratin, and then we will be going for TT, especially in upper neck node, we'll be going for TTF, TG, and
inconclusive morphology, histology.
The first time IHC markers in inconclusive morphology in an upper neck swelling will be TTF, TG, calcitonin, pancytokeratins.
Suppose it is an undifferentiated tumor or poorly differentiated tumor. So which are the sites that where the malignancy has come from, metastasis has come from?
Again, we go in such a case where still the diagnosis remains elusive. We look for hidden areas in the oral cavity, which include the piriform fossa, the retromolar trigone, as well as the floor of mouth and a base of tongue. After evaluating these areas, we again should look for the areas that are below the clavicle. Again, go for this. Again, raises a suspicion of an adenocarcinoma, which again becomes a metastatic disease.
And also in a poorly differentiated carcinoma, the 4 DDs that we keep in mind are melanoma, lymphoma, sarcoma, and NET. So melanoma of head and neck, especially, there can be regression of these tumors or a trivial history of excision, which could be a cause for a poorly differentiated neck nodal presenting as a unknown primary.
What's the percentage split of these diagnoses? The melanoma, sarcoma, and lymphoma. How many percentage when it becomes
In the overall cups, exact percentage.
I can't hear.
Setting of cup, the overall setting of cup, they are very less, but the exact percentage we are not sure.
Last 2 minutes. Last 2 minutes.
So how will you manage in case of that you have not got any primary tumor? So what's the next step?
Again, if you have not got any primary tumor, in our setting, in our case, we take it as a case of squamous cell carcinoma. And in our setting, we have taken it as a case of an N3C, where there is an extranodal extension, because this will come under the category of a bulky disease. So we'll definitely send the patient for a concurrent chemoradiation. Chemoradiation is given together. The regimen followed is usually cisplatin and 5-fluorouracil along with radiation. This is the regimen that is usually followed. If at all, if it comes out as a low volume disease or a less bulky disease, again, we considering that it's a squamous cell carcinoma, we send the patient for definitive surgery, which is a modified radical neck dissection. After which, we check the nodal burden of the patient. And if it comes out that there are more than 2 lymph nodes at 2 different levels are positive, or 2 different lymph nodes in a single setting show metastasis, we again send the patient for an adjuvant radiotherapy. If at all it comes out that there's only a single node that is positive, we'll keep the patient on observation. Instead of going for any further treatment, we can observe the patient.
Okay, you said that your lymph node is in the level 3 lymph node. So which are the areas draining to level 3 lymph node?
Areas draining, it can be from the oral cavity, the oropharynx, the base of, the lateral aspect of the tongue, the floor of mouth. The thyroid malignancies can metastasize to level 3, submandibular malignancies, or etc.
Nasopharynx, oropharynx, hypopharynx, supraglottic space, oral cavity.
Yeah.
What's the theory of true cup?
What is the theory of why there is unknown primary? What is the theory behind it?
So there are a few theories. The first one that we previously discussed are antibodies against these tumors, like especially in melanoma, that can cause regression. Then the second theory that is proposed is that the metastatic node is growing faster than the primary itself. That even it is causing something that could be saying like a Steele phenomenon, where the metastatic tumor is outgrowing the primary, because of which there's an unknown primary.
Also, there can be autoantibodies that can attack the tumor cells and cause regression of the primary tumor, but the metastasis will thrive.
Because of angiogenic incompetency also.
Last question.
What is a significant node in a USG? A node which is suspicious of malignancy. What are the findings? Can you explain?
So in USG, a significant node in a neck region is defined as greater than 1 centimeter node, and it should be having a shape index of more than 0.5, which means that it is a rounded node. There should be a loss of patty hilum, and then also the pericorticular halo will be lost. And any other fixity or anything to the adjacent structures will also make it a significant node in the cervical region.
Thank you.
Extracapsular extension, hypoechoic also. That is also significant.
Yes.
Thank you. Team LP can make their presentation. Yes.
Sharing. Can you see
Not
the
yet. Not yet.
not yet? Share.
There is a green button in your toolbar, which, yeah, it's coming. It's coming, it's coming. You go to the slides to move. Yeah, that's fine. Great. Go ahead.
Good evening all. I am myself Dr. Parvati. This is Dr. Lavanya, Dr. Mohan, Dr. Radu. We are representing team TDMC Alappuzha. Our patient is a 32-year-old male, farmer by occupation, resident of Alappuzha. He presented with chief complaints of pain over the right lower abdomen for past 4 months with associated swelling in the right lower abdomen for a period of 1 month. History of presenting illness. The patient was apparently normal 4 months back when he developed pain in the right lower abdomen, which is dull aching type, occasional and colicky in nature, which was insidious in onset, gradually progressive over 4 months, which is aggravated by males and relieved by passing flatus, either flatus or stool. The swelling was first noticed by the patient 1 month back as a fullness in right lower abdomen, which is gradually increased to the present size. It was associated with occasional episodes of loose stools also, which was foul smelling and mucus mixed. There is no history of any tenesmus, fresh blood dripping after defecation. There is history of fever, which was low grade with the evening rise of temperature. There is history of night sweats for past few months. He gives history of weight loss of around 8 kg in past 2 months. He says that the clothes were loose. He complains of generalized weakness for past few weeks. And he also gives a history of intermittent non-productive cough for 1 month. There is no history of any hemoptysis. There is no history of any trauma, prior abdominal surgeries, no history of jaundice or melena, no history of any urinary symptoms like dysuria, hematuria, no history of any hemoptysis, no breathlessness at rest. There is no history of any oral ulcers, no history of any perianal discharge, fistula or skin tags, no history of any appendicitis, no swelling elsewhere in the body. Going to the past history, there is no prior diagnosis of tuberculosis. He is not a non-diabetic hypertensive or no history of any cardiac disease, no history of any previous abdominal surgeries, no history of any intake of long-term medications, no non-drug or food allergies. His personal history, he's consuming mixed diet, predominantly non-vegetarian. His appetite is markedly decreased over past 2 months, and sleep is disturbed by night sweats and pain. He's a reformed smoker, consuming around 10 pack years, quit 1 year ago. He's a occasional alcohol intake. No history of any tobacco chewing or any other substance abuse. Family history. There is no confirmed TB contact in his household, but there is history of pulmonary TB for close friend, and he is on treatment now. No significant family history of any colorectal carcinoma or GA malignancy. No family history of any inflammatory bowel diseases.
Coming on to the examination. On general examination, patient was, after getting informed consent, the patient was exposed adequately. A patient was examined in a well-lit room with adequate privacy in supine position with hips flexed. On general examination, the patient was moderately built and nourished, conscious, oriented, and febrile. The temperature was 99 degree Fahrenheit, 92 beats per minute pulse, which was regular, normal in volume and character, no radioradial or radiofemoral delay. Blood pressure was 106 by 70 millimeter of mercury, measured in the right arm in supine position. Respiratory rate was 18 per minute. SpO2 was 97 on room air, and he had a BMI of 18.1 kilogram per meter square. On examination, patient was conscious, oriented, and febrile. There was mild pallor. There was no jaundice or icterus, no clubbing, no cyanosis, no pedal edema, no generalized lymphadenopathy. On abdominal examination, coming on to the inspection, the abdomen was scaphoid. There was mild fullness in the right iliac fossa, which was visible in the tangential light. There is no distension, no visible peristalsis or pulsation. The umbilicus was central, inverted, and no discharge. The skin, there was no dilated veins, no striae, scars, or discoloration over the abdomen. The abdomen, all quadrants of abdomen moved equally on respiration. There was no restricted movement. The hernial sites, there was no visible swelling or impulse on cuff. The external genitalia was grossly normal. There was no visible spinal deformity, no visible supraclavicular nodes. On palpation, the abdomen was soft. There was no local rise of temperature or localized tenderness in the over the right iliac fossa. There was no guarding or rigidity. There was no rebound tenderness. On examination, there was approximately a 6 into 5 centimeter mass in the right iliac fossa, extending medially 2 centimeter from the midline and laterally 3 centimeter from the anterior superior iliac spine. The swelling was oval-shaped, irregular, fixed swelling with variable consistency. It had an ill-defined superior and inferior border. The swelling was non-pulsatile. The Rosing sign, SOA sign, and obturator signs were negative. There was no hepatosplenomegaly. There was no renal angle tenderness or spinal deformity. The supraclavicular fossa examination, there were no palpable nodes. On percussion, the right iliac fossa mass was dull. There was dull note over the mass, which was non-shifting dullness, and the rest of the abdomen was tympanic. The liver span was around 12 centimeter. The trough space was tympanic. Shifting dullness was negative. On auscultation, bowel sounds were heard. It was slightly increased, and there was no bruit over the mass. On perrectal examination, there was no perianal skin tags, no fissure, no fistula in ano, no external hemorrhoids. Anal tone was normal. Rectal mucosa was smooth, no mass within the rectum, no blood or mucus on globe. Fecal staining was present on the globe. No extraluminal mass was palpable. Prostate was normal in size with median sulcal palpable. Coming on to systemic examination, on respiratory system examination, there were cause crepitus at the right upper zone. There was normal vesicular breath sounds in other lobes. There was no wheeze. Cardiovascular system, S1, S2 were heard. There were no murmurs, no added sounds. CNS examination, patient was conscious oriented. Cranial nerves were intact. Motor and sensory systems were normal. Deep tendon reflexes were present bilaterally. Plantar reflex was flexor. There was no meningeal signs. On musculoskeletal system, there was no gibbus, no spinal tenderness, or no joint swelling, and oral cavity was essentially normal. To summarize, we have a 32-year-old male farmer from Alappuzha presenting with a complaint of 4 months of right iliac fossa pain with 1 month history of a progressively enlarging right iliac fossa swelling with history of occasional loose stools, low-grade fever with evening rise, night sweats, and history of significant weight loss. He also gives a history of contact with a TB patient. He is a reformed smoker. On examination, patient was malnourished with mild pallor, and there is a 6 into 5 centimeter oval-shaped irregular fixed swelling with variable consistency and ill-defined superior and inferior border in right iliac fossa, extending medially 2 centimeter from midline and 3 centimeter from ASIS laterally. There were post crepitations in the right upper lobe of the lens. From the history and examination, we came to a probable diagnosis of hyperplastic ileocecal tuberculosis.
Very well presented. I would like to start with asking you, what are the contributing factors in history that led to your diagnosis of ileocecal TB?
Yeah, so in this case, there is a young male presenting with the complaints of gradual pain over the right iliac fossa. So a painful diffuse swelling in the right iliac fossa with history of altered bowel habits, and loss of weight, night sweats, and
temperature,
a history of contact with the TB patient, and irregular, firm, fixed swelling with variable consistency, which is pointing towards something inflammatory condition. So, probable diagnosis to be TB.
You said in your presentation, it is given that there is evening rise of temperature also, right? That is one of the characteristic history point. Why is there evening rise of temperature in a TB patient? What could be the reason?
Because it's a chronic granulomatous condition. There will be a release of cytokines. The cytokine release will be there. That causes the temperature, and also there will be diurnal variation.
And the cortisol level will be very low in the day going. Means in early morning it will be very high. When in the evening it will be low.
Yeah. To be precise,
so
because of the circadian rhythm, there will be less corticosteroid release at night, leading to less suppression of cytokines, causing increase in evening rise of temperature. So, which is the most common part of GIT that is affected in ileocecal TB?
Peritoneum.
Sorry, in abdominal TB. Sorry.
It's a peritoneum. Ascitic peritoneum.
Most
Peritoneal TB.
Most common site
GIT.
Most common location. Most common location. Sorry.
Most common location. See, abdominal TB can present as peritoneal TB, gastrointestinal, lymph nodal, solid viscera, anywhere. In the GIT, ileocecal region is the most common site to be affected.
What would be the reason behind the that location? Why is it more common?
Yes.
High lymphatic.
Yes, there are
stasis of food because there is a stasis of food. Then there is high abundance of lymphoid follicles. So stasis causes increased contact time. Also, the food is in the liquid form.
Digestive action is lower and maximum
also
absorption.
Because there is a maximum absorption of bacteria. And you said about pain in this patient. What is the cause of pain in this patient?
Inflammatory condition causing peritonitis.
When it involves the visceral peritoneum, it causes diffuse
stitching of
type
the
of pain. Then
stretching of the visceral peritoneum.
Also, because it's a hyperplastic process, there can be there can be subacute intestinal obstruction also causing the pain. And what is the relevance of asking the history of CKD in this patient? Is there any relevance?
Renal tuberculosis.
Yeah, chronic kidney disease, peritoneal dialysis used to be a common procedure. So abdominal TB, seeding of the peritoneum is a common mode of infection leading to abdominal TB. And how will you differentiate in your history IBD from ileocecal TB? Just in your history.
Alternative diarrhea and constipation.
That is also seen in IBD. But contact with the TB patient, past history of pulmonary TB, usually all the symptoms will be similar, but past history of TB and contact with the TB patients is usually the differentiating point.
Okay. So coming to your clinical examination, can you tell me what are the boundary of right iliac fossa? Inferiorly inguinal ligament, medially, midline between.
Laterally ASI
anterior superior spine.
So
up to thickest level.
Superiorly the transtubercular line and medially the midclavicular line. Laterally ASI. So area between the transtubercular line, right area between the transtubercular and midclavicular line.
And left. Okay. What are the important structures there in right iliac fossa?
Appendix is there, cecum is there, the terminal ileum is there, ileocecal valve, and in females,
lymph nodes can be there.
Lymph nodes also there. In females,
ovary, fallopian tube.
Ureter and
Yes, with the
These are the
retroperitoneal
normal
process.
structures, but then
If there is unascended kidney and
there can
undescended
be
testis can also go.
Unusually it also will be. Yes, okay. What are the clinical features which are favoring your diagnosis in this case?
There is loss right leg fossa mass with pain, loss of weight and loss of appetite, evening night
signs.
temperature with associated night sweats.
Okay, on
And
clinical
irregular
examination.
mass, irregular fixed mass with a slight tender over the mass.
Okay, and also
With varying consistency.
the consistency, yes, the consistency also. What could be the reason behind pallor? You were mentioning you had pallor in this patient. What's the reason behind pallor?
anemia, chronic disease may be one reason.
Multiple reasons.
Chronic granulomatous disease. And if there is a malignancy also, right side colon malignancy will
Present as anemia.
Anemia due to occult bleeding.
Also, if there is any ulcerative process,
that can also
that
be
can also
bleeding
cause.
and
Ulcerative also, yes. Okay, what is the plane of the swelling in this case?
Intra-abdominal, intra-abdominal, intraperitoneal.
Intraperitoneal. How do you differentiate a parietal mass with the intraperitoneal mass?
So there are multiple tests. Basically, the concept is to make the abdominal muscles taut and to observe whether the swelling becomes prominent or diminished. On making the abdominal muscles taut, if the swelling becomes diminished, it is intra-abdominal, and if it becomes prominent, it's a parietal swelling. For making the abdominal muscles taut, we can either ask the patient to raise the legs in extended position, or which is called Carnet's test, or to raise the head and shoulders with the arms on the chest by tauting.
Can a retroperitoneal mass also present like this? A retroperitoneal mass?
It can also be a retroperitoneal mass.
How do you differentiate?
A retroperitoneal mass is usually fixed. So the ideal position was earlier they used to do a knee elbow position. In that position, the mass there is fall forward of the mass, but because it is awkward and uncomfortable to the patient, we ask the patient to stay in a left lateral position, and if there is no fall forward or the swelling is restricted movement, it is retroperitoneal rather than the intraperitoneal.
Yes. And also there won't be limited moving with respiration, and also intrinsic mobility also won't be there.
Yes.
Okay. You are mentioning about shifting dullness. How will you elicit a shifting dullness? Can you explain briefly?
Okay, first, so dullness
is palpate. Patient in supine position palpate circus from the circus in the midline from the suffustum to umbilicus towards the umbilicus, and then
the point of dullness
and
umbilicus to flank. Then mark the site of resonance. Then we will ask the patient to roll, shift to the left lateral position, and we will also resonate percuss from lateral medial position.
Yeah, almost there is a slight change that you have to after telling supine position word and tell initially palpate the abdomen for any mass, then to avoid the percussion over that, and after percussing from below suffustum to symphoid pubis, we have to percuss right to know where there is dull note, not resonant note. Okay, dull note. We have to mark it, then turn the patient, then again. Okay.
We are halfway through. We are halfway through.
Okay. What is the relevance of rectal examination in this patient?
If we have one DD of Crohn's disease, in that case also there will be perianal skin tags, fistulas will be there, and there will be
multiple fistulas. Fissure in ano can be there. If there was any distant metastasis of a malignancy, it can be palpated as Bloomer shelf nodules, or it can also be pelvic abscess or pelvic mass, any abdominal lump which has descended out to the pelvis, that can also be palpated.
How are you different?
So, very well presented. So you have arrived at diagnosis of an ileocecal tuberculosis, right? So what were the differentials that came into your mind? What were the differentials that you considered?
To ileocecal TB, maybe CAC come.
Appendicular
mass due to any appendicular malignancies?
Yeah.
Other than that,
So as you said, there could be an it could be an
This can
appendicular mass.
also be a TB. Inflammatory.
So as you said, it could be an appendicular mass. It could be a case of carcinoma cecum. Also, it can you can also consider a diagnosis of a psoas abscess.
Lymphoma.
You can consider a differential diagnosis of a psoas abscess, as you said, a lymphoma. Also, some rare conditions that you need to keep in mind is an undescended testis presenting as with a malignancy. So that is why the examination of external genitalia is important in this case. You also have to rule out an undescended testis presenting with a malignancy. That is one important differential that we usually miss. So you made a diagnosis of an ileocecal tuberculosis. How will you investigate your patient?
First, we will do the routine blood investigations. In the routine blood investigations, there will be anemia. We will look for the hemoglobin. There will be anemia, and there will be lymphocytosis also. In differential count, there will be lymphocytosis. There will be raised ESR and CRP, and further
routine investigations also with LFT, RTs. Then X-ray, chest X-ray and abdominal X-ray.
Since there is a history of TB in this case, we have to look for pulmonary TB.
Source of the TB.
So a source of the TB because they can be associated pulmonary TB also. So to look for that, chest X-ray can be taken, and also sputum for management for investigating the TB. Also, we can use sputum culture, sputum AFB, and CBNAT. Confirmatory test as site B and IGRA can also be done.
Again, are all of these will all of these give you a differential? Will all of these allow you to reach or help you to reach a diagnosis of an abdominal tuberculosis like an ileocecal TB, the sputum TrueNAT, and all of these? Will it in any way contribute to your diagnosis of an ileocecal tuberculosis?
This is just to rule out the first to look at the baseline condition of the patient, and then to look for the whether there is any active TB. Then to look for the abdominal condition, we have to go first do a USG to know the origin of the organ of origin.
So what will you expect in the USG? What is the finding that you're expecting in your USG, in your ultrasound examination? What do you expect in your case?
To rule out any appendicular mass and other to rule out other diagnosis also.
Asymmetric thickening of the cecum and terminal ileum with normal or maybe mass formed appendix at other surrounding.
Basically, there is also the added benefit of ruling out an obstruction. You can also rule out an obstruction through a USG. So what will be the next imaging that you'll do?
CT.
So can you enlist some named signs that you can see on radiology? There are a particular name signs in a case of ileocecal tuberculosis, right?
Flushner sign, Sterling sign is then Flushner sign is thickened ileocecal wall with wide open ileocecal wall with narrowed increased angle of ileocecal angle.
Yes.
Sterling sign is
also
rapid.
Continue. Yeah, you can continue.
And asymmetrical thickening of that cecum and terminal ileum. Then Sterling sign is rapid passing of dye from ileocecal area.
So you've kept a differential diagnosis of a carcinoma cecum here, right? So if it was, how would you rule out that it's not a case of carcinoma cecum? I'd give you, if you are given the opportunity of doing a single investigation, you're just given the opportunity of doing a single investigation. Patient can afford only a single investigation, and you have to rule out, or you have to be very sure that it's not a carcinoma cecum. So which investigation would you suggest to the patient?
Serum CA can be done, blood investigation, and colonoscopic biopsy.
Yeah, definitely. Serum CA is not. I was just giving a single investigation. So if you can go,
we will go for colonoscopy and biopsy.
Exactly. You should not go for the blood levels of the tumor markers. You should go for a colonoscopy and a biopsy.
Okay. So abdominal TB is a very difficult diagnosis, right? So what is actually the investigation of choice for abdominal TB, like including ileocecal, peritoneal? What is the investigation of choice as per the guidelines? Do you have any idea?
Colonoscopy biopsy, diagnostic lab, peritoneal biopsy.
So biopsy,
demonstrating
biopsy.
with granulomas.
So are these actually diagnostic? What is the proportion of patients where you take a colonoscopic biopsy? First of all, what are the tests that you will do for after taking a biopsy from the ileocecal region? What are the tests that you will send for?
questions can be sent for
HB
CBNAT,
histopathology, CBNAT,
histopathology examination, CBNAT, AFB.
AFP,
Yes. And
as
one
a
more?
specially
So definitely,
Definite.
presence of acid-fast bacilli or a granuloma is the definite sign that will give us definitive diagnosis of TB.
No, actually, okay, yes, okay, yes, if it's positive, but you also have to do culture, by the way. If it is positive, but only 50 to 60% of the TB patients are going to have positivity in these places, right? So the essence of diagnosis here, first of all, let me come back to my previous question. The investigation of choice as per guidelines for ileocecal TB is actually CT colonography, CT enterography, all right? So that is the first thing. Second thing is that, okay, so you are getting doing a colonoscopy, your HPR is coming, some granulomatous inflammation is coming, but your AFP stain culture, everything is negative. All right. So how are you going to proceed with management of this patient? You are getting granuloma in your HPR, which is going to be case, okay, but then your AFP staining culture, everything is negative. So how are you going to proceed?
Diagnostic lab.
All
We
right.
can proceed
Actually,
with the diagnostic lab.
symptomatic.
So there is a diagnosis of presumptive TB that you can make based upon your risk factors, clinical features, and also the presenting symptoms. This patient has crossed capsules in the right upper lobe, right? So you're suspecting PTB in this patient as well. So you need to take a CT chest also. Yes. Yes. So what is the ATT regimen that we use?
In our case.
Yeah. So what is the ATT regimen?
4 months of 2 months of HRSD, that is isoniazid and isoniazid, rifampicin, pyrazinamide, and ethambutol, and 2 months of HR. That is a
yeah. Okay.
Based on the complication, it can extend up to 9 to 12 months also. Usually, you are given in the 6 months duration.
All right. So this is a setting of presumptive TB. So at the end of intensive phase, what are the tests that you need to do for this patient to see whether your treatment is working or not? Because you're not getting a microbiologically confirmed TB, right? So how are you going to proceed? At the end of intensive phase, what will you do?
You have just 1 minute more.
All right. So at the end of intensive phase, you have to do for a repeat colonoscopy and look for regression of mucosal lesions. If at the end of the intensive phase, if the patient is getting symptomatic worsening is there, or the mucosal lesions are increasing in size, what is going to be your differentiation diagnosis? What is the reason for your failed treatment? What would be the reason for your failed treatment? What is in your mind? What are you going to do?
One is MDR TB. Then C missed colon carcinoma.
Okay.
Then
actually, the first differential that should come to your mind is called Crohn's disease.
Crohn's disease.
Yes. So, okay. So, what are the indications of surgery in ileocecal TB?
Failure of medical treatment. Then acute surgical emergencies like obstruction, perforation,
peritonitis,
hemorrhage.
Okay. So now if suppose your case like you said, actually it's stuck. I can't see them. Anyway, so
hello.
Yeah. All right. So you said that if it's failed medical treatment is an indication for surgery. Is that so? Actually, it is not. You need to rule out other differential diagnosis. You cannot go for surgery for a
getting worsening.
Then Crohn's Crohn's, right? Okay, so last question.
Your last question.
What is the reason? What is the etiology? How does the pathogenesis of ileocecal TB? How does TB reach there?
One cause is Mycobacterium bovis by infected cow milk and
pasteurized cow
milk. Then swallowing of sputum infected with TB self inoculation with pulmonary TB patient. It may cause two type of TB, one ulcerative, one hyperplastic. The Mycobacterium.
Just the etiology. How do you acquire it? There's one more method of spread.
Then hematogenous spread also.
Yes, very good. And also adjacent organs. Adjacent organ, lymph node TB, and also like in females, pelvic TBs. All right. So you were telling about that hyperplastic TB, right? So you were talking about diagnostic laparoscopy as well. So in a TB, what is a classical diagnostic laparoscopic finding that is going to confirm your diagnosis? If you're doing a diagnostic lab, what is the standout feature in TB? Like one feature that's going to be there. That will be
Structures pulled up cecum will be narrow contracted ileum with pulled up cecum.
Peritoneal TB is there, aside
Patent lymph nodes.
peritoneal.
You are close actually. Peritoneal. You're close. What are those called? Tubercles. So that will be the diagnostic.
Thank you very much. Thank you very much. Let me have a few words from Dr. Rajan Gurula.
Thank you.
Dr. Rajan. Dr. Rajan. You're muted, Dr. Rajan. You're muted, Dr. Rajan. You're muted.
Yeah, unmute.
You have come through two devices.
Both the presentations and the questions from both sides were in great detail. I could not find any lapses or absence of any questions.
Thank you. Dr. Ashok.
Yeah. Both congratulations to both the team. They discussed the cases very well. Just a few. One, I thought that GMC Trivandrum, when they presented their neck mass, it looked quite obviously nodular. It was not just an irregular mass. I think it looked quite obviously nodular with early skin involvement. Then the issue of branchial fistula was quite unnecessary. I thought it was not a relevant discussion there, branchial fistula. That is not the site for a branchial fistula. It had nothing to resemble a branchial fistula. Then probably a few words about neck dissection could have been discussed, because that is something you discussed in the exam also. Then regarding the right leg fossa mass, history of contact with tuberculosis, some more details could have been given about the contact with tuberculosis, whether it was a family member or a co-worker. Retroperitoneal mass, how do you differentiate it from a retroperitoneal mass? Somebody said knee elbow position, the right leg fossa. I thought that is not very appropriate. DD, inflammatory bowel disease, should have been discussed a little more. And how do you rule out intestinal obstruction by, they said ultrasound. I think probably intestinal obstruction you can rule out with an X-ray. You don't need an ultrasound for that. And the role of surgery in this particular lesion, one of the things is after your treatment, there's no resolution and diagnosis is still uncertain. Probably you should consider it. So these are just some additional points that I would like to mention. Otherwise, both the teams did well, discussed well. Congratulations.
Thank you, Dr. Ashok. Dr. Sandeep.
Yeah, good evening. Just a few points. Trivandrum, when you show your picture, it's better to cover the eyes, even though we are showing the lateral view. Always cover the eyes. And if I heard correctly, you said the diagnosis N3C. I don't know whether it's N3C in head and neck cancers. We only have till N3. So that's one point. And try to avoid showing signs on yourselves while explaining, like on your neck or something like that. In Alleppey, I don't know why you said Rosing sign, Soas sign, obturator sign, because they're all seen in acute appendicitis, and we're talking a case of around 3 to 4 months history. And when questions are asked to you, you're all 2 or 3 people answering together. Try to avoid that. One person should answer or let other person answer. And classical, like last question on laparoscopy, diagnostic laparoscopy, you see peritoneal nodules, because we don't know whether it can be TB, it can be malignancy or anything. You're looking for peritoneal nodules, and that we take for a biopsy. And that's also. Thank you.
Thank you very much. I think the examiners will communicate with the the key people behind this and announce who have won the matches, and they will both move to the semi-finals. Dr. Ranjan, anything more from your end?
No, so it was both the quarterfinal matches were excellent. They fought very well and let the examiners decide the final things. Nothing more to add, sir.
Thank you. Dr. Madhu, anything from your end?
Nothing, sir. Just so we want the result at least by tomorrow evening. Let them discuss. I mean, just the second match, if they can give us a consensus winner, so we can have the semi-finals drawn out by tomorrow evening. That's all. Thank you.
Thank you very much. We'll meet at the same time tomorrow. Till then, stay safe and good night to all of you.
Good night, sir.
Thank you.